Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Right now, there is a surgical technique sitting completely dormant in a hospital database somewhere, and it could potentially save thousands of lives.
Yeah, but it will probably never be seen by the wider medical community.
Exactly. And why is that? Because the brilliant surgeon who actually performed it, well, they didn't know the mechanical difference between a good clinical outcome and a publishable case report.
Right. It's a notoriously wide gap.
It really is. And, if you're a surgeon or a doctor tuning in right now, you know exactly that feeling you've just scrubbed out of a grueling, maybe a 4 or 5 hour complex case.
Oh, yeah, the adrenaline is just starting to level out.
Right. The monitors are finally quiet, you're peeling off the gloves, and you look across the OR at your team, and someone says that classic line, "We should really write this up."
I hear that at least once a week.
Right. But there's this massive, frustrating gap between saying, "We should write this up," and actually, holding a published, highly cited case report in your hands.
The road from the operating theater to a peer-reviewed publication is just littered with abandoned drafts. I mean, missing data, manuscripts that get mercilessly desk-rejected by editors.
It's not because the medicine was bad, right?
No, not at all. It's usually because the translation of that medicine to the page was just flawed.
And bridging that gap is our mission for this deep dive today. We are going to break down the exact anatomy of a successful surgical case report.
Which is so needed.
Yeah, we're pulling directly from modern guidelines, journal author guides, and structured clinical literature to create a highly efficient shortcut for you to get your cases published without wasting your incredible limited time.
Because surgeons do not have time to waste.
Exactly. But before we jump in, we need to lay down our standard mandatory disclaimer. This deep dive is for reference and educational purposes only. You must always follow your local guidelines and institutional protocols in your actual clinical practice.
Yeah, absolutely essential to keep that at the forefront. We are analyzing publication strategy and academic rating today, right? We're not dictating your surgical approach or your patient care.
Right, exactly. Okay, let's unpack this. I feel like early career surgeons in particular, they look at everything as a revelation. Like every difficult day in the OR feels like it belongs in a journal.
Oh, for sure. That is probably the most common trap authors fall into.
So how do we objectively measure if a case is actually adding value to the global literature rather than just being, an interesting day at work?
Well, a case might be deeply fascinating to you personally. Maybe it pushed your technical skills to the absolute limit, but that doesn't mean it adds actionable knowledge to the global surgical literature.
Right.
Like routine guideline concordant management simply doesn't make the cut. Journal editors are looking for very specific indications that elevate a case from an everyday struggle to a universally publishable report.
So we basically need a filter. What specific criteria are editors actually using to separate the signal from the noise?
So the literature outlines 4 main categories that pass the test. First, you've got a rare disease, a bizarre anatomical variant, or an unusual presentation that is directly relevant to general surgery.
Okay, so think of an incredibly rare hernia variant discovered during a routine laparoscopy.
Exactly. Second, and I'd say this is arguably the most valuable and unexpected complication, a severe adverse event, or just a total failure of standard treatment.
Wait, I want to bookmark that. Because learning from when things go catastrophically off the rails, that feels so counter to surgical culture.
It is, yeah. But those cases carry massive teaching points.
Wow. Yeah, what's the third?
The third category is a novel or modified surgical technique. But the caveat here is that it cannot just be different for the sake of being different.
Right. You can't just invent a new knot and call it a day.
Exactly. You need a clear, mechanistically sound rationale and measurable advantages to a specific technical problem.
Makes sense.
And finally, the fourth category is a diagnostic or therapeutic dilemma. This is where the case illustrates exceptional clinical reasoning, or maybe it highlights a glaring, dangerous gap in the existing evidence base.
So I visualize this as the difference between spotting a unicorn in the OR versus just a regular horse that happens to have a funny gallop.
That's a great way to put it.
But let's look at the reality of a surgeon's schedule, right? They are running from the ward to the clinic to the theater. How do they prove this case is actually a unicorn and not just a manifestation of their own, limited experience with a particular pathology?
Well, they have to do the legwork before writing a single sentence. This is honestly where so many clinicians waste weeks of their lives.
What do they do?
They write a 3,000-word paper, they submit it, and then the peer reviewers immediately point out that 15 identical cases were published in the last 3 years.
Oh, man. That's brutal.
It is. You have to prove the novelty to yourself first. That means executing a highly focused search on PubMed or Google Scholar based on your specific condition, technique, or complication.
So it's essentially a defensive maneuver against desk rejection?
Precisely. A 30-minute focused literature search acts as an academic shield.
Right.
High-yield cases often emerge from chaotic emergency lists or complex reoperations or unusual intraoperative findings. The raw material is definitely there, but verifying its novelty is what justifies the time you are about to spend writing it up.
Okay, let's say the 30-minute search confirms it. The unicorn exists. It is genuinely novel. The problem now is human biology, right?
Oh, memory decay.
Yes. The cognitive decay of memory is aggressive. The specific nuances of why you chose one approach over another during a chaotic bleeding emergency that's going to evaporate from your mind very quickly.
And that memory decay is exactly why timing is the second most critical factor after novelty. The sources outline a very pragmatic 8-week blueprint to counter this.
So you have to start documenting while the case is still acute.
Yes, absolutely.
What is the mechanism behind that 8-week timeline? Because, trying to reconstruct the decision-making process of a complex patient a month later sounds like an absolute nightmare.
It is virtually impossible to do accurately, which is why weeks 1 and 2 of this blueprint are entirely dedicated to raw capture.
Just grabbing everything you can.
Right. You are securing the detailed operative notes, the specific intraoperative photos, the imaging, and the pathology reports.
And I imagine institutional archiving is a major bottleneck here.
Huge bottleneck. If you wait a month, getting specialized imaging out of a hospital's PASS system can become a bureaucratic nightmare. Capturing it in week 1 ensures you actually have the visual evidence.
That makes total sense.
And most importantly, you must establish a chronological timeline of events while the patient is still on the ward.
Okay, secure the perimeter before the evidence degrades. I like that. What happens in the subsequent weeks?
In weeks 2 to 4, you transition from capture to context. This is the deep dive literature search.
So going beyond that initial 30-minute check.
Exactly. You already verified the novelty, but now you are identifying the 15 to 20 key papers that will form the backbone of your discussion section.
Got it.
Finally, weeks 4 to 8 are dedicated to drafting the manuscript using a standardized structural guideline, and then you circulate it to your co-authors for rigorous critique.
I look at that 8-week blueprint, and my immediate thought is, when does an attending surgeon who is already double booked have the bandwidth to actually draft this?
Yeah, it's a lot.
But the sources offer a brilliant systemic solution here involving trainees. It shouldn't just be an attending's burden, right?
Handing that 8-week blueprint to a resident or a fellow is the ultimate force multiplier in academic medicine.
It shifts the dynamic entirely. It saves the attending's time, yes, but it acts as this intensive apprenticeship.
Absolutely. The trainee learns how to navigate the ethical review boards, they learn the mechanics of academic writing, they develop critical literature appraisal skills.
And they get a first author publication out of it.
Exactly. It builds the academic muscle memory for the next generation of surgeons. But, whether it is the trainee or the attending doing the typing, there is a massive brick wall you have to clear before a single word goes to a publisher.
The ethical gatekeepers.
Yes, the ethical gatekeepers.
Because you can have the perfect timeline and the most novel technique in the world, but if you fail the ethical criteria, the manuscript is basically dead on arrival.
Ethical integrity is absolute. Modern guidelines and reputable specialist journals consider these non-negotiable hurdles.
So what's the primary hurdle?
Written informed consent. You must have explicit, documented consent from the patient or their legal representative, specifically for the publication of their case and separately for the publication of any clinical images.
Okay, let me push back on this with a hypothetical because I know this frustrates clinicians all the time.
Sure, go for it.
Let's say you are on an emergency trauma rotation. You perform a groundbreaking modified technique that saves a patient's life from an otherwise fatal injury. It's a genuine medical miracle that other trauma centers desperately need to know about.
Right.
But the patient recovers, they're discharged, and they're completely lost to follow-up. They just disappear. Do you just sit on a technique that could save lives?
This raises an important question, and it really highlights the tension between academic progress and medical ethics. But the rule from the sources is unequivocal.
Which is?
Without consent, the case should never be submitted, period.
Wow, no exceptions.
No exceptions. The historical context here is vital. Medical literature has a very dark history of exploiting vulnerable patients without their knowledge.
Right.
Today, the patient's fundamental right to privacy supersedes the academic desire to publish, no matter how life-saving the technique might be.
That is a very sobering reality check, a hard stop.
A definitive hard stop. And, parallel to consent is the requirement for strict de-identification.
Which isn't just about deleting a name, right?
Exactly. You must remove hospital numbers, exact dates of admission, and exact dates of birth.
But don't you need some of that for clinical context?
Yes. The nuance here is that you must retain the age, sex, and relevant demographics, because those factors are clinically vital to understanding the pathology.
That makes sense.
You must also proactively check your local institutional policies. Some hospitals require formal institutional review board or IRB exemption just to draft a case report.
Okay, so the ethical perimeter is secure. We have consent, we have the raw data, we have the literature. Now we have to actually construct the manuscript.
Yes. The actual writing.
And we are targeting specialist journals here, like the International Journal of Surgery case reports. But they have strict word limits, usually capped at 3,000 to 4,000 words.
Which means every single sentence must justify its existence. And to do that, you cannot just free write. You absolutely must follow the structural guidelines, specifically CARE or SCARE.
Let's define those for the listeners really quickly. CARE stands for the Consensus-Based Clinical Case Reporting Guideline Development. And SCARE is the surgical-specific variant of that checklist.
Right.
Reading through these guidelines, it instantly reminded me of the WHO Surgical Safety Checklist. I mean, in the OR, you don't just wing it and hope you remember to check the patient's area risk. You go line by line.
That analogy is perfectly aligned with the editor's mindset. Skipping a step on the WHO checklist in the OR physically endangers the patient.
Yeah.
Skipping a step on the SCARE checklist on the page guarantees your manuscript will be rejected.
It's that serious.
Yes. These checklists were created to eradicate the old era of rambling, anecdotal medical storytelling and replace it with rigorous, transparent science.
So let's walk through that anatomy. It starts with the title, which I assume cannot just be an interesting case of abdominal pain.
No, definitely not. The title must be highly utilitarian. It must include the key phenomenon, so the specific diagnosis, the technique, or the complication. And it is mandatory to explicitly include the words case report in the title itself.
Why is that mandatory?
It feeds the indexing algorithms. It makes your paper instantly searchable for the next surgeon who finds themselves in a similar clinical bind at 3 in the morning.
Ah, that is so smart. Okay, so after the title and the structured abstract, we hit the introduction. And this is surprisingly brief, usually just 200 to 300 words.
The introduction serves one primary function, and that is context. It summarizes why this specific case diverges from the established literature.
Just setting the stage.
Exactly. And crucially, this is where you explicitly state that your report complies with the SCARE or CARE criteria, and you cite that guideline.
It's like slashing your credentials at the door to show the peer reviewers you actually respect the methodology.
Exactly like that.
Then we move into patient information. Demographics, comorbidities. But there is a detail in the sources regarding this section that I found incredibly powerful. The guidelines highly recommend reporting the presenting complaint in the patient's own words.
Yes. Incorporating the patient's voice grounds all that sterile clinical data in the human reality of the illness.
Which is so important.
It is. And alongside that narrative, you need a timeline table.
Why a table specifically? I mean, why not just write out the sequence of events in a paragraph?
Cognitive load. Peer reviewers and fellow surgeons are reading dozens of papers a week, summarizing the presentation, the imaging dates, the operative intervention, and the follow-up milestones in one visual figure dramatically reduces the friction of understanding the case.
It organizes the chaos of a complex admission into a digestible format.
Exactly.
That makes the transition to the diagnostic assessment much smoother, I'd imagine. The labs, the ultrasounds, the CT scans. But the sources emphasize that you shouldn't just present the final correct diagnosis. You need to highlight how misleading initial impressions were systematically resolved.
Medicine is almost never a straight line, and the false starts are highly educational. But once the diagnosis is secured, we arrive at the most critical section for this specific audience, which is the therapeutic intervention, or the operative details.
Now, as you know, the daily operative notes surgeons dictate are primarily geared toward billing codes, hospital record keeping, and, basic legal protection. I assume we are not just copying and pasting that dictation into the manuscript.
Oh, that is a guaranteed path to rejection. The mindset shift here is profound. You are no longer writing for a hospital coder. You are writing a replication manual for a fellow specialist halfway across the world.
A replication manual. I love that phrasing.
Yeah, a surgical case report requires immense mechanical depth. You must describe the planned procedure and then explicitly detail any intraoperative changes to that plan.
So was it an open approach or laparoscopic? What was the precise patient positioning?
Exactly. You need to provide a stepwise breakdown of the critical maneuvers.
And visual evidence is non-negotiable here, right? The sources mandate intraoperative images or detailed diagrams, especially if you are dealing with atypical anatomy or repairing complex defects.
Without images, a novel surgical technique is just a rumor.
Just a rumor. That's good.
And you also need to integrate the pathology results, both macroscopic and histological, especially if they dictated the surgical margins or confirmed the diagnosis.
Okay, here is where it gets really interesting, funny. The surgery is done. Now we have to document the follow-up and outcomes. Length of stay, functional status at 3, 6, and 12 months.
Right.
But human nature, especially in highly competitive fields like surgery, makes us want to project perfection. We want to publish our triumphs. How do journals handle failures?
The push in modern surgical literature is toward meticulous honesty. You are actually encouraged to publish failures, provided they contain a clear mechanical or systemic lesson.
That's refreshing.
It is. Outcome reporting must be objective. You must detail early complications using a standardized taxonomy.
Like the Clavian-Dindo grading system mentioned in the sources.
Exactly. Clavian-Dindo isn't just a buzzword to make a paper look smart. It removes subjective, useless terms like a minor complication or a major event.
Because minor to me might be major to you.
Exactly. Instead, it categorizes complications strictly by the level of therapy required to fix them.
So, did it require pharmacological treatment? Did it require a return to the operating room under general anesthesia?
Yes. It standardizes the language of failure.
And publishing that failure is incredibly vital. I mean, if you attempt a novel technique and it fails spectacularly due to a specific anatomical limitation, publishing that exact failure prevents 10 other surgeons from repeating your mistake.
The academic literature acts as a shared global brain. Hiding failures corrupts that shared brain. We really have an academic duty to share the errors alongside the triumphs.
Which brings us to the most analytical part of the paper, the discussion. You've laid out the clinical story, you've shown the operative photos, you've admitted the complications. But if you stop there, it's just an interesting anecdote.
Right.
How do you turn that narrative into a global, actionable tool?
I like to view the discussion section as the black box flight recorder of the case.
Oh, that's an interesting analogy.
It is where the true academic value is forged. You aren't just summarizing the crash, the complication, or the rare presentation. You are analyzing the altitude, the engine pressure, and the weather data.
So you are exploring the underlying pathophysiology that explains why the patient presented that way.
Exactly. You are shifting from what happened to the mechanism of why it happened.
And how it compares to existing published series, I assume.
Yes. And furthermore, you have to critically reflect on your own decision-making. You must acknowledge the limitations of your own report.
Like admitting that this is only a single case.
Yes, or that you lacked a specific advanced diagnostic test, or that your follow-up period was too short. Admitting those things doesn't weaken your paper. That transparency actually builds immense trust with the reader and the reviewer.
The SCARE guidance is incredibly rigid about how you close this out, aren't they? It's not just a fading summary.
No, not at all. SCARE mandates that you end the discussion with 3 or more clear bullet point take-home lessons.
3 bullet points.
Yes. This forces the author to distill thousands of words of complex narrative into highly actionable, universally applicable advice. If another surgeon only reads those 3 bullet points, what must they know?
That discipline really forces clarity. So if the bullet points do the heavy lifting, what is the function of the final conclusion paragraph?
The conclusion is a distinct, highly concise paragraph. It states the singular overriding lesson of the entire case in plain clinical language. And crucially, the sources dictate it should contain absolutely no references.
Oh, really? No references at all?
None. It is your final, unvarnished synthesis of the case.
Okay, so to synthesize this entire deep dive for the busy clinicians listening, Write a report only when your case genuinely teaches a mechanical, diagnostic, or systemic lesson that extends beyond the walls of your own OR.
Prove it's a unicorn with a literature cert.
Yes, use that 8-week blueprint to combat memory decay, leverage your trainees to build their academic skills, and secure written patient consent before a single word is drafted.
And treat the scare checklist with the same reverence you treat your surgical safety checklist.
Absolutely. Be brutally transparent about your complications and translate your experience into actionable take-home lessons.
If we connect this to the bigger picture, it really comes down to respecting the word limits and your reader's time. The ultimate goal is clarity and clinical relevance.
Quality over quantity.
Exactly. A tightly constructed, scare-compliant 3,000-word report is infinitely more valuable to the medical community than a rambling 6,000-word essay.
It truly is a masterclass in concise clinical communication. But before we sign off, I want to leave you, the listener, with a final thought to mull over.
Let's hear it.
We talked earlier about how modern guidelines increasingly mandate the patient perspective in these reports. They want the patient's own voice describing the illness. It makes me wonder, if every surgical case report in the future absolutely required the patient's own view on their post-operative quality of life, how might that fundamentally change the way surgeons perceive and define surgical success?
That is a profound paradigm shift. I mean, a flawless technical success on the operating table does not automatically equal a functional success in the patient's daily life.
Exactly.
Forcing the literature to bridge that gap might just be the next great evolution in academic surgery.
Something to seriously consider the next time you are scrubbing out and looking at your monitors. If you found the strategies in today's session valuable, please do not forget to share this with at least one of your colleagues or friends to help spread the word.
Yes, please do.
Also, check out our YouTube and other social media pages for visual breakdowns, and be sure to check our previous season and episodes with some very relevant topics. Thanks for diving deep with us today. Keep an eye out for those unicorns, and make sure you write them up the right way.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.